Ça va, Bernard?
Oui, oui. Tout est bon. De mon côté, tout est parfait.
Donc, okay, I believe we can start. It's 5 almost. So, hi everyone. Again, I'm Philippe Landreau, DxBone Chief Medical Officer, and thank you again for attending our number 4 live broadcast for DxBone forum. You know that probably for those who attend already, the previous one, it's done to maintain our educational platform interaction with different profession, surgeon, of course, but doctors, physiotherapists, nurse. And by the way, it's an opportunity to wish Nurse Day, to celebrate the Nurse Day 2020, because it's exactly today that 200 years ago, Florence Nightingale was born. So it's a big day today. All the respect for all the nurses in the world, especially in this difficult period. So we come back to our presentation. You know that this is a live broadcast, but you will be able to see anytime in the future this video on our channel on YouTube. In our 4th live forum, I'm very happy to have back my colleague and friend, Dr. Bernard Lallemand, our senior orthopedic surgeon specialized in upper limb and hand surgery. He is Belgium, and he has a vast experience across Belgium, Luxembourg, Qatar, and now joined our DxBone team to drive this project of excellence. I will be moderating this time. For any question you may ask, you can use the chat box, which is close to the video, depending on the device that you're using. And we will do our best to answer all your questions. You know that this session, the aim of this session is to be very interactive, and we are here to answer to your question and different remark or experience. My dear Bernard, merci d'être ici. You have the microphone, and please lead us through your presentation about lateral elbow pain.
Thank you, Philippe. So first we will share the screen. So, yes, Philippe, as you say, lateral elbow pain. But what we know, lateral elbow pain is not only about tennis elbow. So before starting this, as you said to our nurse, I wish them a happy Nurse Day, and thank you for all what you are doing during these difficult days. Thank you, everyone. So concerning this presentation, I have no disclosure. So when you receive a patient, the first things you see when he's presenting with a lateral pain of the elbow, you always think about the tennis elbow. And as you know, the tennis elbow is a really long story. The first time it was described in 1873 by Runge. And the world long tennis elbow was done in 1882. As you see, it's a really long story. And over time, this entity became known as tennis elbow or lateral epicondylitis. What is tennis elbow? It's an overuse of the wrist extensor and the supinator muscle. The most affected muscle is the extensor carpi radialis brevis. So just a reminder for the anatomy to understand what we will discuss during this topic. This is the lateral epicondyle on the distal part of the humerus. You have the extensor carpi radialis longus, and under that, the extensor carpi radialis brevis. These two muscles are the extensor of the wrist. You will see posteriorly the small muscle, the Anconeus, and below them, more deeper, you will have the supinator. And in yellow, you can see the posterior anterossus nerve. So lateral epicondylitis, tennis elbow, affect almost 1 to 3% of the population each year. It's a touch with the same equality, the male and the female, around the 4th and the 5th decade. And it's mostly the dominant arm that is symptomatic. So the patient came with pain on the lateral elbow with irradiation really often on the forearm. They complain about weakness during the grip, and the pain is localized on the lateral epicondyle. There is multiple provocating tests, chair test, Bowden and Thompson test, personally allow to use the Mills and the Cousin test when you test the extensor capil radialis brevis, and the Maudsley test when you use the extensor of the fingers. For any suspicion of tennis elbow, you should do and start with X-rays to exclude any bony problem. The ultrasound is really useful, especially if you have a specialized radiologist to see the affected tendons. The Doppler ultrasound could be interesting to see any neovascularization that is an indirect sign of inflammation, but the MRI is the most reproducible exam. And when we have the diagnosis, the main, you need to start with a conservative treatment, and the main goal is to first control the pain with preservation of the movement to improve the grip strength and the endurance of this grip strength. So to return to a normal function. There is a multitude of conservative treatment like bracing, rest, non-steroid, physiotherapy with eccentric exercise, shockwave therapy, laser, acupuncture, epicondylar strap, injection of corticosteroid, or PRP. Surgical treatment are also really complex. You can do percutaneous release, open surgery, arthroscopic treatment, denervation of the lateral epicondyle. But this is not the topic of today, and I will not start to discuss about the big surgery we can do for this tennis elbow. Because I really see really often patients, they come back to me and say, I've tried everything, but I still have pain on the lateral side of my elbow. And my reply is, that's normal, because all lateral elbow pain is not only about tennis elbow. You should understand tennis elbow is the muscle problem, but we have bone, we have joints, we have nerve. And one of the most unknown diagnoses is the radial tunnel syndrome. The radial tunnel syndrome is a rare compressive neuropathy of the posterior interosseous nerve. The patient complaining about pain, but doesn't have any motor or sensory dysfunction. It's most women between 30 and 50 years old. The incidence was shown in 2010 around 0.03%. If you compare to the carpal tunnel syndrome, where the incidence is 0.1% to 0.3% in the general population each year, it's 3 to 10 times less. So the radial tunnel syndrome was first described in 1956 by Mitchell and Kruger like radial pronator syndrome, what is totally nonsense because there is no pronation on the radial side. So, and then Rhodes and Mosley, who described the Mosley test, described the first time a resistant tennis elbow with a nerve entrapment. And they found there is a compression of the posterior interosseous nerve. And the terminology of radial tunnel syndrome was only used in 1993, where we described that there is a compression of the posterior interosseous nerve by the supinator. And the nerve is the radial nerve. As you know, the radial nerve is coming from the posterior cord of the brachial plexus, C5-T1, innervate some muscles, and at the level of the radiocapitellar is dividing in two branches, the superficial and the deep branch. The superficial branch is only sensory branch and will follow the brachialis to finish on the first web space. The deep branch, the posterior interosseous nerve, go more deeper and go between the superficial and the deeper belly of the supinator muscles. So there is different level of compression during this radial tunnel syndrome, but the two most frequent are the arcade of Rose, is the proximal part of the supinator, and the supinator itself. So the patient are coming to you with pain more diffuse and involving not only the epicondylar, but also the posterolateral aspect of the forearm. You can find 5 centimeters below the lateral epicondyle an exercise pain when to the compression. And if you do an active extension of the wrist and the middle finger, you will have confirmation of this diagnosis, because unfortunately, this patient could have no pathology in the MRI because it's not a tennis elbow, and you have really rarely some muscle edema of the supinator or atrophy of the finger extensor. Sometimes the MRI could show you there is, like in this case, a radiocapitellar cyst that can compress the nerve. So the electromyography, unfortunately, are quite atypically normal in this patient with radial tunnel syndrome, even if you ask them to do some exercise. And you have two major studies, one done by Rosen and his colleague. They show there is no difference between the motor latency at rest and after active resisted supination. But you have a different study that showed that there is a difference, and the differential latency is about 0.3 milliseconds after the dynamic testing. It's really a difficult study to reproduce. So for me, electromyography doesn't bring a lot of information in radial tunnel syndrome. The treatment is initially always conservative treatment with modification of the activity, some non-steroid anti-inflammatory, and night time removal splint with the wrist in a slight extension. I don't recommend at all any radial tunnel steroid injection. Sometimes this conservative treatment failed, and we need to go for a surgical treatment. So there is different way to approach this radial tunnel syndrome. There is three planes to approach the posterior anterosys nerve by the dorsal way, and only one by the anterior way. And you can see here an anterior approach to the patient that I show you the MRI. You see here the radial nerve, and you see here the ganglion. This is the sensory branch, the anterior branch, and you see the posterior anterosys nerve compressed by the ganglion. After the surgery, you see the posterior anterosys nerve here and the anterior sensory branch. So otherwise, I prefer to use an approach laterally dorsally through the brachioradialis to approach the posterior anterosys nerve. And you will see here on this picture and this picture, so this in yellow, it's the posterior anterosys nerve. You see here the proximal part of the supinator called the arcade of Rose here, and this is the superficial belly of the supinator. This is the extensor, the fascia of the extensor carpi radialis brevis, and it's where the nerve is compressed. And what we need to do during a 10-15 minute surgery is to repair the nerve and to release the fascia of this Bose method to avoid any further compression of the nerve. So, but you will tell me, yes, but what is the difference between the radial tunnel syndrome and the so-called posterior anterosys nerve syndrome? It's quite confusing, you're totally right. But the thing is, the posterior anterosys nerve syndrome is a neuropathic compression, and the patient come usually without pain, but they have a palsy, partial palsy, a loss of extension of the MCP joint of the finger, or eventually a completely palsy of the extension of the MCP joints. So MRI and EMG play this posterior anterosys nerve syndrome an essential role to clarify the diagnosis. And if you have any partial or complete palsy, you should go for neurolysis and maybe another surgery. Another nerve injury is really rare but common to the thrower in athletic population is the lateral antebrachial cutaneous nerve entrapment. And this nerve has nothing to do with the radial nerve. This nerve is a continuation of the musculocutaneous nerve, and it could be compressed by the lateral margin of the distal biceps tendon. We can see this regularly to the throwing athletes when the arm is in full extension and pronation during the following through phases of throwing. And you can see the patient will come with burning sensation, pain on the lateral side of the elbow and the forearm. And the nerve is entrapped just at this level and giving the burning sensation. So the nerve conduction could give you some good idea about the latency of this nerve if you have really good electromyographies. And the nerve can be seen under ultrasound or MRI to see if there is any neuroma. That's it for the pain related with the nerve. Now we will go more deeply in the elbow and we will discuss about the joint and the bone. And first, other diagnosis is the osteochondritis dissecans, the classical OCD. It's a musculoskeletal problem that appeared in the maturing skeleton. And as you know, when we discuss about OCD, it's an acquired lesion of the subchondral bone. It's nothing to do with the cartilage. It's you have a resorption, a fragmentation, or a sclerosis under the cartilage. It's the same then in the knee. And the etiology is multifactorial. It's first multiple repetitive trauma, vascular inflammation, and maybe genetic factors. You can have OCD everywhere in the elbow, but the capitellum is one of the most common sites for this lesion. And you can see this lesion to the adolescent athlete, especially those that are doing some repetitive overhead activities like javelin throwers, like swimmers, or the weightlifter. And it's between 11 and 17 years old. And this osteochondritis is due to the blood supply of the capitellum. And Harrison in 1959 described the blood supply of the capitellum between two arteries, the radial recurrent arteries branches and the interosseous recurrent from the branches. So you will have here, like for the scaphoid, a non-well-vascularized zone of the bone. So the patients are usually coming to you, the young patient, this teenage patient, they are coming with a progressive worsening pain related with the activity. And you will find a pain on the lateral side, just at the level of the radiocapitellar joint. Sometimes you can see some stiffness, especially a lack of extension that could reach 30 degrees of lack of extension. And occasionally you can have catching, clicking, locking side when there is a loose body. So initial imaging, like for all the lateral pain of the elbow, is radiographic with 3 views. First, the AP view in a full extension and the lateral view. But in this case, if you have any suspicion, you should do the 45 flexion AP view. It's exactly the same than for the knee, the so-called shoes view. So as you can see here from this book of Journal Orthopedic Science in 2017, it's a beautiful example of A and B. You have a beautiful AP view and a beautiful lateral view of this teenager. And you can see something, a flattening and something in the subchondral bone of the capitellum. But it's more evident when you ask to do the 45 flexion of the elbow, where you can see there is a really osteochondral lesion. And sometimes it's good to do an oblique view of the capitellum. And Minami did the classification, and it's quite easy to remember it. If you see some really flattening or cystic changing in the capitellum, is a grade 3. If there is any intra-articular loose body, it's a grade 3. Grade 1 for the first one, and grade 3 for the second one. And what is between grade 1 and grade 3? It's grade 3. So to analyze the bone, you can do a CT scan. But as it is a problem that affects the teenage, I prefer to go to MRI because it's really the best imaging to evaluate any OCD lesion. And it can demonstrate early stage lesion that you cannot see on X-rays. And these are the image you will find in sequence T1 and T2. So from the book that I discussed, the article that I discussed, I took this beautiful imaging where you can see here really advanced osteochondral lesion on a CT scan, sorry for that, and the flattening of the MRI with a loose body on the anterior part of the capitellum on the MRI. And then you have the diagnosis, what to do. Takahara in 2007 drew this simple indication for conservative treatment and operative treatment. I will start with the last. If you have a stable lesion with still open physis, a full range of motion, and a Minami grade 1, you don't do surgery, elbow rest, and non-operative treatment. But if there is any instability, closed phasis, a restricted motion over 20 degrees of lateral extension and a minimum grade 2 or 3, you should go for surgery. So the conservative treatment should be always tried when the indication is good. It's immediate cessation of all sports activity. Sometimes it's interesting to put brace for a period of 1 to 6 weeks to avoid any stiffness. And after this period, we will start the physiotherapy to keep the range of motion. We will not start any strengthening before 2 months. The athlete could start gentle overhead throwing after 3 months, but not return to play before 6 months, and a confirmation with the MRI that everything is going better. If there is failure or unstable lesion, we need to go for surgery. And the surgery is arthroscopically done most of the time, removal of loose body, doing gesture on chondroplasty, like drilling, microfracture, in situ fixation, or we can go for osteochondral transplantation. And you will see here in arthroscopy, some loose body removal, cleaning of the lesion, and microfracture when you can see some blood. Or in this case, still under arthroscopy, you can do an osteochondral transplantation that you take on the knee to put on the elbow. So one another disease of the bone is the Panner's disease. And you should not confuse between the OCD, the osteochondral, and the Panner disease, because the Panner disease was reported by Mr. Panner in 1927. It's a correlation with the Calvé-Perthes disease of the hip. It's an avascular necrosis of the humeral capitellum. So the Panner disease happens below the age of 10, so between 7 and 10 years, and the patient have no trauma. So you see, based on these two diseases, tennis elbow doesn't exist to child and teenage. So for the Panner disease, it's really often in baseball, and it was reported in America, in the United States, in the Little League elbow for the baseball player. And the pathological mechanism is due to an insufficiency of the medial collateral ligament due to the throwing, resulting in a compressive stress of the radial head and the capitellum on the lateral side. And you can see on the X-rays some changing, that subchondral changing, and in the bone you see on the X-ray, and you need to do an MRI to confirm that this is a Panner's disease. Always try a conservative treatment. It gives really good result. And if there is any evolution with loose body, even the patient is really young, we need to go for surgical treatment, like for the Osteochondritis Dissecans. So we stay in the joint, the radiocapitellar synovial plica. Plica, you heard it a lot in the knee. It's when you have an impingement of a hypertrophic inflammatory synovial, and it provokes snapping with the patella. But as you know, the synovial plica is a remnant of a normal embryonic development of the synovial membrane. It's something that we have in quite all the joints. But normally, the plica doesn't give any problem. We don't have any symptoms. But occasionally, when it starts to be a little bit thick, especially in the radiocapitellar joint, we can have problem. And this hypertrophy could follow some trauma or repetitive activity, especially to the throwers. The patients are coming with pain on the lateral side. They have some catching sensation on 50%, like the snapping painful, and they can have in 30% a mild lack of extension between 5 degrees to 20 degrees. So recently, posterolateral radiocapitellar plica test was described in 92. It's a compression on the so-called soft point, and you create a flexion of the elbow. And around the 30-40 degrees, you will create a pain with a snapping of the plica. The MRI is the best exam to see and this plica, and you can see in FATSAT T2 image that there is a hypertrophic plica between the capitella and the radial head that you can see there. So in 2018, Lee and his colleague made a beautiful review about only 20 cases, and in 15 you have only posterior plica. Only in one case you have anterior plica, and in 4 cases, so almost 20%, you have a posterior anterior plica. So the plica are really regarding the posterior part of the radiocapitellar joint on the soft point. Conservative treatment should be tried minimum at least 3 months with modification of the activity, physical therapy, and non-steroid anti-inflammatory. I suggest to do cortisone infiltration of the soft point to reduce the inflammation of the plica. And if this treatment failed, we need to go for a surgery. And the surgery is arthroscopic debridement, and can be done in a daycare clinic under local regional anesthesia. And you will see on this other video here, this is the shaver, this is the radial head on the left, this is the ulna, and this is the capitella. And you see this really thick synovial tissue that is going between the radial head and the capitella that I started to remove with the shaver. And you understand when you look at this that during the mobility, the extension and the flexion, that this plica will be pinched by the two bones and create this pain. And after doing the job, you see here with the palpator, I have the annular ligament of the radial head. There is still a little bit plica there that I removed after that. And you see that the posterior part of the radiocapitellar joint is completely free and there is no more pain. So another problem, we go a little bit out, is the posterior lateral rotatory instability that could create problem. It was described recently in 1991 by O'Driscoll like an injury of the lateral ulnar collateral ligament. And this injury leads to a subluxation of the radial head on the capitator. So you have 3 ligaments, the annular ligament that I show you in the arthroscopy, you have the radial collateral ligament, and you have this really small ligament that is really important in the stabilization of the radial head, is the lateral ulnar collateral ligament. Most of the time, the ligament is injured after a dislocation or a really significant vasovagal stress combined with an axial load. But you can have this problem after an injection of steroid or after extensive debridement of the lateral epicondylite. So the patient comes to you with lateral pain, especially during the activity when he places the elbow in extension and supination. And sometimes he can describe a clicking and a locking and a snapping pain, most predominantly at 40 degrees. And you will tell me, how can I make the difference between the plica and this instability? First, the history, and then you have 2 specific tests. The O'Driscoll test, that called the posterolateral rotatory pivot shift test, is exactly the same test that you do for the knee, for the pivot shift test for the knee. So you put an axial compression in the joint and you put a full supination and you will have a subluxation of the radial head as you have for the knee with the tibia and the condyle. Otherwise, Reagan proposed this chair push-up test, so you can do it easily. You ask the patient to extend, and they will directly have an apprehension sign of the elbow, and they will not be able to do the full extension. The X-ray, unfortunately, because it's a dynamic instability, it's mostly normal. And what is really interesting is to do this test under fluoroscopic. The MRI can show some lateral collateral ligament injuries. So you can see here on the fluoroscopic some instability, the dorsal instability of the radial head and the lateral instability. So non-operative treatment are often unsuccessful in the chronic case, and the majority of the patient needs to have surgery, and the best result is when the surgery is done early. Then, again, inside of the joint, you need to do, and you will see this, about 2 things. First, the patient could have osteoarthritis, simply. So rheumatoid osteoarthritis is quite a well-known story for the patient, so it will be easily seen. And sometimes when they have all the injuries, they could have a radiocapitellar post-traumatic arthritis, because the primary arthritis is really rare in athletes and general population. A simple X-rays will show some arthritis between the capitellum and the radial head. Another problem is the seronegative arthritis. And this will be seen by MRI and described by the radiologist, where you can see some enthesitis on the lateral side of the elbow. It's not really a common arthropathy, and it could not be seen by the laboratory test. But if you have any doubt for that, just ask the advice to the rheumatologist. And the last is the Anconeus syndrome. So the Anconeus, as you know, is a small muscle on the lateral side, as I showed you before. It's attached proximally in the lateral aspect of the, on the dorsal aspect of the lateral epicondyli. It's a triangle muscle innervated by the radial nerve. And this muscle has a really weak action. It's a weak accessory extensor of the triceps, and it could place the abduction when the ulna is, could place an abduction of the ulna during the pronation. So the last research showed that it play around 15% of the extension, but we can use it for some transfers, so without any problem. So, and what is this Anconeus syndrome? It's a chronic compartment syndrome well known in the forearm and in the lower leg. There is a few case reports described in the literature, but you need to think about it. And one of these reports show a beautiful MRI result when you have on this Anconeus, this edematous due to this chronic inflammation. And the patient come to you with a swelling at this level and some pain. So the treatment, it's easy, should be conservative treatment with a specific treatment during the first 6 weeks and then progressive strengthening. And if you have a failure of this treatment, you should go for a simple fasciotomy like for all compartment syndrome. So the take-home message, it's quite easy. Lateral elbow pain is not only about tennis elbow. You need to think about first the nerves. Look essentially about the radial tunnel syndrome. If you have lateral elbow pain to young patient, child and teenage, it will be an osteochondritis dissecans lesion or Panner disease under 10 years. If you have any snapping, think about the plica, the radiocapitellar plica, and the posterolateral rotatory instability. The difference could be done by the history of the patient, especially if he had an injury or an infiltration, and by the clinical test. And then it's why you always need to do also X-rays when you have lateral elbow pain. It's to avoid any osteoarthritis or rheumatologic disease. And you should think about the Anconeus, but it's a really rare message. So thank you for your attention, and let's start the discussion for the question, and don't forget to subscribe to our channel.
Thank you, Bernard, for this excellent presentation, like usual. I think the attendees know much better now about the cause of lateral elbow pain, which is multi-cause, multi-etiology. So it's probably not so easy, and it can explain why in practice some diagnoses are missed or diagnosed, I would say. And I believe that your presentation clarified the things. We have a couple of questions. I will go chronologically. There is a question from Mir Ibrahim. His question is, can upper thoracic spine have a role in tennis elbow? So I think to summarize, could you have some neurologic cause from the thoracic spine to explain?
Thoracic spine is impossible. Thoracic spine is impossible. Cervical spine, yes. You can have, because, I discussed that about the radial nerve. So radial nerve is coming, as I told you, from the cervical spine, the dorsal part of C5 to C7. And yes, if there is any, I will say, if there is really nothing on the elbow, just have a look on the spine. But the cervical spine, not the thoracic spine, because thoracic spine doesn't send any nerve for the pelvic.
And I have another question from Sofiane Kalel, who is a good friend, great Tunisian surgeon. Hello, Sofiane. Thank you for your question. The question is about the OCD. And he asked if the MRI remains best for OCD. And I would have to have the same question about arthro CT scan. Can you clarify what is the best imaging?
So it depends the quality of the MRI, for sure, because it's better to have a good arthro CT scan than a bad MRI first. I think first the OCD in this level happens in young patients. So I don't like to do a CT scan and an arthrogram associated with arthrogram to a teenage, because it's quite invasive and irradiating. So with the new technology, and I think Dr. Landreau will discuss this further, but the MRI give more best results than the same results than the arthro-CT scan in the OCD, especially in the early case. Maybe you could have some interest to do an arthrogram CT scan if you suspect unstable cartilage injuries. This is, for me, the only reason that I will do the arthro-CT.
Because we know that the cartilage is not really nicely viewed with the simple MRI. It can be an arthro MRI, but injection definitely can help in some case. I have another question from Feti Regag. The question, the text is this one: lateral elbow pain in youth athlete, capitellum, OCD, prognostic, Panner's disease, prognostic. So I understand that the question is about the prognosis when we see this kind of articular lesion of the youth athlete. What could we expect? Is it bad? Is it good or depend for the future?
Two things. First, I will start with the Panner disease. The Panner disease is it's an avascular necrosis of the bone. The patient comes quite early, and if you think about the disease, you will treat them only with rest, and within 3 to 6 months, you will have a great result. I never had to operate a Panner's disease. But the OCD, the osteochondritis, if they don't follow the rules, and sometimes the evolution is not even with the rest good, you need to go for surgery. But it's you should start when the indication and you are too early stage, wait a minimum of 3 to 6 months, and don't hesitate to repeat after 3 months an MRI, and after 6 months before let the patient go back to activity, because the most of the teenage are throwers, are swimmer, are weightlifter. So it's really difficult because they are high-level athletes, and they are elite athletes, most of them. It's quite difficult to make the coach and the parents to understand that they should put a break of minimum 6 months in the career of the young population. And believe me, it's not because you will operate them, they will go faster to play.
Okay. If we talk about nerve, I try to manage the question. If there is a question from Thierry, in terms of differential diagnosis between the C6 radiculopathy, radial tunnel syndrome, and PIN, means posterior interosseous nerve. What is the role of clinically? How can you differentiate during the clinical examination? And what about the electrophysiologic testing? Of course, it's a question from Thierry, but I'm sure he has the answer.
Yeah.
And, especially for a practitioner who not having the clinical experience. I think he's right to ask the question, when you don't have when you're not specialized and you are not used for this kind of thing, can you give us some tips, tricks, something about some element for that?
I will tell you one clinical sign. First, the pin, as I told you, there is a motor extension. So they have a lack of extension of the MCP joint. So the pin syndrome is quite easy. There is a motor dysfunction. So when you have a deficit of extension, and I will exclude all tendon injuries, it will be a pin syndrome or a cervical spine problem. So it's quite easy to see. You don't need to do anything else. You need to send him to the neurologist, to Thierry, to do an electromyography. For the radial tunnel, is clinical diagnosis. So as I told, you have a pain just here, 5 centimeters on the supinator. When you press there, you can create the pain to the patient, and you can compare with the other side. And the patient will feel the pain, really this excised pain. And this is the diagnosis of the radial tunnel, because the patient have pain at this level without any motor and sensory, because it's no more the sensory branch at this level. They have only pain without any motor weakness. So if there is any motor weakness, I send it directly to electromyography to exclude any problem, pin syndrome or cervical spine syndrome. If there is no motor weakness and pain 5 centimeters distally to the lateral epicondyle, it's a right.
Yeah,
and I will manage it by conservative treatment. Yes. Did I reply to the question?
Perfect. And just to mention that pin, because you are used to use this pin for people who are not used, and there is another question which show that it's important to repeat that it's a posterior anterossus nerve compression. And yes, I think it's answer to the question. I hope, otherwise he will intervene. I have another question. We said that from Anand Balasubramanian. He said, thank you very much, Dr. Bernard. Is it safe to say that posterior pin, posterior anterossus nerve syndrome, will not present with any sensory symptoms as opposed to radial tunnel syndrome, where one may have sensory deficit? So you just
yes.
Answer.
The pin is only motor. There is no sensitivity in the posterior anterossus nerve. And if there is any associate motor and sensibility, it's because the compression is over the division. So it's over the radiocapitellar joint.
Yeah. Question for Faraz, from Faraz Seti. So thank you, Dr. Bernard. He said, very kind, not many people can make the joint exciting. So it's very nice. He said that in my experience as a physiotherapist, the symptoms of cervical spine and upper extremity injuries often overlap, which require clinicians to distinguish between the two in order to accurately diagnose. In your clinical, so you, Bernard, in your clinical experience, how many times has your initial diagnosis of tennis elbow pain been incorrect? Never, no? Tell never.
Really, because I test everything, yes, it's really rare that I go for a tennis elbow, and it's not a tennis elbow confirmed in the MRI.
Yeah, because I know you. I know that each time you investigate an elbow, it's always the same sequence, and you never say it's a tennis elbow. It's it's when it's sent.
I will say we need to stay doctor. First, history. Second, clinical examination. And as you know, we find only what we know, and now you know everything about the lateral elbow with the examination you need to do. So when you know, and as you suspect and you have an idea, you will ask the good exam and you will have the good results.
Yeah. I don't think I would check if we have some question. There is one question that before to forget, you didn't mention something which is quite special. It's the nursemaid's elbow, the pronation douloureuse, which is quite special. But if you can give just a few words for the people who don't know that. So, I'm sure everyone knows. But
the nursemaid elbow, if you want, is not a posterolateral instability. So, and it's not a Panner disease. The nursemaid elbow is between the age of 1 to 4 until maximum 6 years. So over 6 years, it's no more. It's no more. I've never seen that, but never say never. It's no more a nurse-made elbow. What is nurse-made elbow? It's totally different. Is a traction done by the maid for the child, and you have a decoaptation between the radial head and the capitellum because the ligaments are not strong. And during this decoaptation, you have the annular ligament, they will go and then will be catch between the two bones, like a plica, if you want. And then it's why the patient has pain, especially during pronation. It's why we call in French, it's a painful pronation. So it's not really a big problem if you suspect a nurse-made elbow. So one thing, or you know how to reduce it and you do it directly, or you don't know how to do it and let it because the nature will do the things within 24 hours. But please, when you have this to a 2, 3 years old, don't start with, if there is no history of fall, with X-rays and especially no MRI. It's clinical examination and historic diagnosis.
Another question I forget because it's in the list. Yeah, from Safa Al-Mansouri, who thank you for the wonderful lecture. How many times you can inject with corticosteroids for tennis elbow?
I will tell you for tennis elbow, I will inject once. It's dependent, really. The topic is not about the tennis elbow, and I did it by purpose because you see, I discuss here only 3-4 minutes, and I think I will do a topic with because we need to discuss about it for really 30 minutes. So I will tell you first, if you want, between steroid and PRP, the diagnosis will be done by the result that I get on the MRI. And if I do injection with steroid, it's one that I will repeat maybe a second time, but not before 6 months to 1 year. Because don't forget, if you inject too much, you will have problem.
And can you have a tennis elbow combined with a radial tunnel syndrome?
Yeah, this is quite tricky because yes, you can have both. So it's why it's really important to do always complete examination of the patient. You don't press on the lateral epicondyle and you say it's okay. No, look if there is no associated tennis elbow, radial tunnel syndrome associated. Why? Because if you remember the lateral view that I showed, the posterior anterossus nerve is entrapped between the supinator and the extensor carpi radialis brevis. So the tennis elbow is an inflammation, chronic inflammation of the extensor carpi radialis brevis. And with time, the fascia will be a little bit hard and will be compressive the posterior anterossus nerve just at the level of the Froese arcade. So for me, it's rare. It's not really often that I need sometimes do operation for the both, but you need to explore the both because if you go for a surgery and you only do something on the extensor carpi radialis brevis most of the time and you ignore or you don't know about the radial tunnel syndrome, you will have not a complete relief and the patient will continue to have pain because they have an associated radial tunnel syndrome with lateral epicondyle.
And if we go back to the injection in general, because there are some questions about that and the people are not sure. For example, when you do an injection in the joint or around the joint, how can we be sure to avoid the iatrogenic injury of the lateral ulnar collateral ligament in practice?
Yeah, it's really important. It's why first don't repeat too much steroid injection because if you put too much, you will have a problem. So the most important thing is to do this ultrasound guided injection to see exactly where you are. And this is why I think to do a blind injection and to go close to the bone and to inject totally blindly, it makes no sense because you can create this lateral collateral iatrogenic injury, and then you will have posterolateral instability. So for me, injection should be done with a vision, and the vision is the ultrasound. So for the tendon, but if you want to do a soft point injection, you go through the Anconeus and you go in the joint. But again, or you do it under ultrasound, you can see the inflation of the capsula, or if you want to do it, you can do it under fluoroscopy with arthrogram injection.
And when we talk about injection, we talk about PRP, you know, the so-called, because if you look at on the internet, there's some miracles. If you, first of all, for example, do you think we can solve the problem for plica or this kind of thing? And in general, could you tell us, just to summarize, in which, and I'm interested because it's something that we don't know very well because there is no evidence clearly. If you want to summarize this pathology, all the pathology on the lateral side of the elbow, in which case we can believe that the PRP can help the patient and not?
So first, for me, we will shortly discuss about the tennis elbow. I think in tennis elbow, when you have some rupture in the extensor carpi radialis brevis, it can help and it's better than the cortisone. So first, for that, yes. For the plica, it's intra-articular PRP. I don't think that the PRP could reduce the inflammation of the plica, especially when it's really hypertrophied. So I think that it's interesting to do steroid for plica. For the osteochondral lesion, for Panner disease, no, and PRP to teenage and children is not recommended at all. So after that, you know, for the arthritis, primary arthritis of it's like for the osteoarthritis, it's like for the other osteoarthritis of the joint, of the knee. We have really no scientific proof about the PRP at this level. And absolutely it's not for any other problem like ligament injuries or like nerve injuries. So PRP, yes, for tennis elbow, we could discuss in other lecture on this, not for the plica.
Concerning injection, I have another question from Rajesh Bijouet, which how to avoid injection is in, I believe it's extensor carpus radialis longus.
Again, the insertion of the both, it's quite difficult to really dissociate the both muscles, but the extensor carpi radialis brevis is a little bit more distally insert and middle insert. The extensor carpi radialis longus is more anteriorly on the lateral epicondyle. So it's why, again, you will see the injury on the ultrasound, you will see the inflammation, you will see the tendon if there is any rupture. So with the ultrasound, you will see where you need to do the injection. So the best way is to do ultrasound guided.
Yeah, again. You mentioned the plica.
Yes.
And I'm a shoulder and knee surgeon, so you know plica, it's something that we know in the knee. We know that it's exceptional, and there is probably some abuse arthroscopy for plica resection because in my career I didn't see a lot of plica, real plica problem. You know the knee, so my first question is it frequent? So it means no frequent, not frequent like the knee, or is it more something that we have to evocate when there is a pain like this? You know, because on the knee, it's clear that it's really the last diagnosis, and it must be a exclusion diagnosis. For the elbow, is it the same thing, or is it something that is really a possible cause in the daily practice?
It's not so rare like for the knee. It's really rare. It's don't make me wrong. I don't say that tennis elbow is so frequent and the plica also. No, it's more rare than the tennis elbow or the radial tunnel syndrome. But it's more often that the plica that you can find in the impingement with the patella. Yes.
Okay. It's a good message. It's important for people. And about the plica, because is it really a synovial plica? Because I saw your picture and I've read some in the past. Is it really a synovial plica, or is it a sort of, I don't think ectopic meniscus like we can, or abnormal meniscus like we can see on the AC acromioclavicular joint, but could it be a sort of abnormal extension of the annular ligament, you know, some abnormality like this?
No, it's not a non-abnormal extension of the annular ligament because it's really a hypertrophic synovial. It's when you do a biopsy of that, it's synovial tissue, so it's not ligament. So the problem is to know if it's like a pseudomeniscus that is there since long time, and then with chronic repetitive snapping start to be hypertrophic and then start to be symptomatic. It's exactly the same than in the knee. It's there, you have there, and it starts to be symptomatic. For which reason, we don't know.
And probably because the joint is smaller. As the joint is smaller, we can understand that the same plica that in the knee will make more trouble in this joint than the knee, probably.
Exactly. As you know, the elbow is a hinge joint. So
I have the question from Ashraf Antuli. Is steroid injection recommended in chronic cases regardless of the increased rupture risk? So can we do that in some chronic case, even if we know that it's not...
chronic case of tennis elbow, I think.
I believe.
Yes, yes, you can try if you believe on it. And, you know, we will discuss it later, but steroid injection in chronic case give good results. And yes, you know, there is a risk, but it's a risk not after only one injection, repetitive injection and wrong side injection. So I will repeat, don't do too regularly the steroid injection on the lateral side and blindly.
Rajesh, it's an exciting topic because a lot of questions. Rajesh Bisway, as I hope I spell correctly, any difference in elbow pain character, so clinical aspect, between Panner and OCD, osteochondral lesion?
No, when it's in early stage, no, they will have soft point radiocapitellar joint pain, exactly the same diagnosis. The only thing is if there is any locking and snapping, this is because it's more advanced. But at the early stage is like, you know, no, it's not really painful. You need to look on it. The patient are not comfortable at the beginning. They describe some discomfort and some pain when they do throwing. So you need to be attentive to this, especially again, between the age of 7 to 17.
And a question from a good question from our Rose Dyson, our physiotherapist, Rose, who asked something, is the shockwave treatment for lateral epicondylitis can be interesting or not?
Yes, it could be interesting, but again, Rose, we will do a topic on this and I will show you all the studies concerning all the different treatment and what is proven in the literature.
Perfect. I think we went through the majority of the question during this session. It was quite active, you know, the interaction, because question from the chat box, question from the WhatsApp, email, and so on. So I think we can close the session because otherwise we can discuss hours. I would like to thank you again for this clarification of the lateral elbow pain. I learned, because I'm not specialist of elbow like you, and I learned during this presentation. It's very interesting. I hope everyone, it's more clear and it's better for the... I have another question from Elfie, maybe the last one. Do you recommend neurodynamics?
For all the neurologic pain?
Probably.
Probably, yes. There is different things that we can do to try, like the TENS. We can try to do this to reduce the pain of the neurologic. It's quite difficult. It's really a beautiful topic that I think we should discuss about this. But yes, for radial tunnel syndrome, we can try it. You
see, we try really to answer all the questions until the end, and this is the concept of this interactive session. So Bernard, thank you very much. Merci beaucoup for your presentation and education, this education session. I think everyone learned a lot, and I hope, and you know that you can see again this if you want to re-listen, or if you miss one part of this video, you can, it's available constantly, permanently on the YouTube and the DxBone channel, and the best way is to subscribe on this channel to be aware and informed about the new video. We will meet again next week. I don't know if we will do that every week for all the time. Probably no, because everyone will be busy. But during this COVID period, I think it's a good opportunity to push the education session. But we will never stop this kind of video anyway in the future. Maybe it will be less than every week, but be sure that we will do our best. We have a lot of topic, a lot of specialists ready to educate everyone, and you will have a good surprise, a lot of people from all around the world joining DxBone to educate and to participate to this education session. Next week, I will talk about the cartilage surgery, because this is something that we use regularly, and probably there is a lack of knowledge about this topic, and I will try to give you an overview and an update on the current concept for in 2020, because it's always constantly moving with new technique, new philosophy probably. And I wish you a nice day, nice week. Stay safe. And I think for everyone it's becoming less difficult, but even though, stay safe, because it's not finished and we have to fight, and with our nurse and all the people working in this field, I hope we will solve this problem and continue our work and medical and surgical activity in a normal way in the future. I hope so. So thank you, everyone. Thank you, Bernard, again.
It was
and see you soon.
Yeah.
Bye-bye. Take care.
Bye.